the portion on prostate MRI. I have no disclosures. So I'm going to begin with just a case to illustrate some points. So this was a patient who had never been biopsied previously and who had a rising PSA. And we have here images from a multiparametric prostate MRI examination, T2-weighted image, the ADC map, a high B image, actually a B-value 1500, and an early post-contrast image. And there's this focal lesion in the posterior right peripheral zone, darkened T2, decreased ADC, increased high B-value signal, rapid early enhancement. And we categorize this as a PI-RADS 4 lesion, which we'll talk more about during this half hour. And the patient then underwent a MRI ultrasound fusion biopsy demonstrating Gleason 3+4 or intermediate grade tumor in that lesion. At the same session, the patient underwent a 12-core systematic biopsy that showed no tumor on the right. And you could think that could be surprising. I mean, this is a posterior lesion very close to the rectum, and you think this would be easily sampled with a standard biopsy, yet it was missed. And the systematic biopsy, though, found a low-grade or Gleason 3+3 tumor on the other side, the left, which we don't see on MRI, in which the fusion biopsy wouldn't have targeted. So here, the systematic biopsy found the low-grade tumor, missed the intermediate-grade tumor. The MRI was the opposite. And I think there's really going to be a compelling role for MRI and MR-targeted biopsy in the future to deal with many of the issues that we're hearing about just from both the lay and medical press and about prostate cancer management today, about the need to reduce over-detection of low-grade prostate cancer and improve our selective diagnosis and treatment of more aggressive lesions. And I think MRI is well situated to do that in the coming years. So I think much of the issue in the current management of prostate cancer relates to issues that relate to standard prostate biopsy and how it's performed. We have to keep in mind there's over 1 million prostate biopsies performed annually in the U.S. Significant cancers are often missed or undersampled. Insignificant tumors are frequently detected. This is a costly procedure with discomfort and side effects, as well as a lack of confidence in results, which can create anxiety and uncertainty about optimal treatment. So there have been significant improvements in the ability of MRI to detect and localize tumor, which can address those issues. So current state-of-the-art MRI has high sensitivity for high-grade tumor. Low-grade tumors are often undetected, and this allows for a new approach using MRI to select patients for biopsy and define biopsy targets. So if we were to think way back before the advent of modern imaging, prostate MRI really relied heavily on T2-weighted imaging alone, but that just really wasn't sufficient to drive targeted biopsy and prognosis with imaging. There's often a heterogeneous appearance of the prostate in T2-weighted images with numerous benign causes of decreased T2 signal, say from atrophy, inflammation, scars. These are two patients who have nonspecific areas of decreased T2 signal bilaterally. Neither of these patients were shown to have tumor in any biopsies they underwent. And this nonspecificity of T2 limited the use of, I think, MRI prior to the advent of more modern imaging. If there's really one thing I think that I'd pick that really has changed this, I think it's been the emergence of diffusion with imaging for prostate cancer assessment. This sequence substantially improves tumor localization, has been a key reason for the surge of interest in prostate MRI in recent years. It's now an essential part of routine prostate MR protocols. And I think we as radiologists can do the sequence well. It's non-contrast, reasonably quick acquisition. We can readily acquire and process these images with our current technology, and we can do this without direct physicist support. So there had been a string of papers all kind of showing the same conclusion that our accuracy for tumor localization improves substantially when we incorporate the ADC maps. Here we have two patients with decreased T2 signal in their peripheral zone bilaterally, non-specific. There could be tumor in either lobe, both lobes, no tumor. We look at these patients' ADC maps, and there's a focal area of decreased ADC in the left on the top patient, focal area of decreased ADC in the right on the bottom patient. These are their dominant tumors on prostatectomy. And again, we'd be hard-pressed to come up with these foci using just the T2-weighted image alone. So in comparison with some other organs where we've interpreted diffusion most heavily relying on the high B image, using the ADC as kind of complementary or to confirm what we were seeing, I think this has really switched in the prostate. In the prostate, we've largely read mostly on the ADC map and used the high B image as secondary. And I think that's because in the prostate, there's a lot of residual unsuppressed signal at standard B values up to about 1,000. So this patient here has a dominant tumor on T2, and we see it well as dark on ADC. On a B1000 diffusion-weighted image, the prostate is still bright, including in the benign areas, and that's obscuring potential high signal in the lesion. So that's actually now changing. More recently, in the last few years, there's been papers looking at what I consider ultra-high B values. These have been in the range of about 1,400 to 2,000. And I think the prostate has really been the poster child among organs where there's been good data supporting B values in this range. All the papers nearly all the papers are having similar results here, that we get better suppression of benign prostate tissue at these higher B values that can improve conspicuity of tumor. So this was the patient on B1000, the prostate is still bright. The B1500 image, there's more background suppression, and this patient's proven dominant tumor stands out better. So we can actually take this one step further. The ultra-high B images might be challenging to acquire due to low SNR and increased distortion and other artifacts as the B values continue to increase. So there's been recent descriptions of computed diffusion-weighted images. Here the ultra-high B values are mathematically generated from the lower B value images, essentially by just fitting a curve, and they're not directly acquired. So this provides the image contrast of the ultra-high B values, but good quality still in terms of distortion and artifacts, and also doesn't require any additional scanner time on top of getting the standard B values. So here we have an acquired B1000 image, and there is some increased signal in the left posterior prostate, but the whole prostate is still bright. Without any additional time, we can compute the B1500 image, and there's more dropout of signal in the benign region, and this patient's dominant tumor now has greater relative conspicuity compared to the rest of the prostate. So I'll just kind of run through now just some similar examples of just the role of ADC in these ultra-high B-value images in the prostate. And I think it's really important we get these images and spend the time in going through these carefully when reading these exams to really detect important lesions. So this was a patient who had a prior negative biopsy. PSA wasn't all that high, 1.8. T2-weighted images, I mean, there's diffuse low signal, kind of difficult to really call any one area. ADC and B1500, this focus in the right anterior really stands out, and probably wouldn't call that right on just the T2 alone. That was actually a 3+4 tumor on fusion biopsy. This patient, again, on T2, a lot of nonspecific changes. ADC and B1500, this focal lesion stands out. And again, that was a 3+4 tumor. I think these ultra-high B-value images are helpful, in particular in the transition zone, for separating BPH and transition zone tumors. Here, a lot of heterogeneity in the transition zone. ADC, then the 1500 image, there's this lesion essentially along the anterior stroma. And again, this was tumor on targeted biopsy. And then just one more case, almost a scary case on the T2 image alone in the ADC map. You could read this as negative. You may not really call anything. And then on a B1500 image, there's this crescentic increased signal along the anterior prostate. And this was called. And on a fusion biopsy, this was like at least a 9 lesion. So again, if we didn't have that image, this might have actually been read as negative. So given how important the diffusion-weighted images are for prostate interpretation, we really have to invest the time in the protocol optimization to make sure these images are of high quality. And this is the sequence that's most prone to anatomic distortion, warping, other artifacts. And I think rectal gas is a source of potentially severe artifacts with this sequence that can render the images non-diagnostic. So here we have a patient with distended rectum, whether it be with gas or stool. And if we look at the ADC, the high beam ADC map in this patient, artifact from the rectum is being propagated A to P in this patient along an AP phase-going direction, and really causing this marked distortion of the prostate that is not really interpretable. So there's numbers of ways of trying to get around this. And a lot of these methods are just things that centers have tried and maybe found helpful. There's really no uniform approach to this or really data supporting these, but these are things to keep in mind and maybe to try in your practice. Could try some sort of light enema or laxative, even for a non-endorectal exam. This might seem a little more than we're used to doing, but actually sometimes we're doing this with okay results, that if the initial sequences show a lot of very distant the rectum, actually then at that point using a small suction catheter to remove the gas, or it's been labeled the phartectomy procedure. So instruction to evacuate any gas before the exam, hopefully not when you're in the room, but step out. And glucagon, this was just to reduce peristalsis, not really help with the rectal gas, but it was, again, mixed data in terms of that. A very practical thing, which many centers aren't doing, but I always recommend it. It's a very quick thing. Is if you're doing this with an endorectal, just swap the phase going direction left to right, so the artifact propagates not on top of the prostate. Here we see the prostate in T2-weighted images. On the ADC map with AP phase encoding, the prostate's a little squished. And if it's just the same patient, swap it to left to right. We can see the prostate anatomically it's a little bit fuller and is more closely approximating the anatomy and shape on the T2-weighted image. As with anything, there are some pitfalls that we just need to be aware of, and there's actually a good number of pitfalls to kind of run through. And these are important because if you're not aware of these, you could misinterpret some of these as tumors. These are just normal findings. So the central zone, this is a histologically and embryologically distinct region in the transition zone. We should not use the central zone and transition zone interchangeably, and we should know where this is a band of, it's largely a minimal glandular region. It's probably muscular by the posterior base that encircles the ejaculatory ducts as they are coming towards the urethra. And we see it here in this image, the CZ, the transition zone is anterior to that, peripheral zone is posterior. And this can have dark ADC as dark, not darker than some tumors. So again, this should not be mentioned, there should be no suspicion for tumor of this region of low ADC. This is just a normal anatomic finding that should be appreciated as such. The neurovascular bundle. So on T2, right, we would see this as outside the prostate. Sometimes on the ADC map, due to distortion, this can actually look like a focal lesion in the prostate. Right? So here we see this little round low ADC, and we think, is that a lesion? And I've actually seen this sometimes get called a highly suspicious finding. But you look and it actually corresponds with T2 with, like the typical round tubular structure with the symmetric finding on the other side, and you can trace it slice by slice. It's just the neurovascular bundle, and it's just, again, a normal finding to be aware of. Right along the junction of the peripheral and transition zone, there's the so-called pseudocapsule or surgical capsule, and there can be some fibrous thickening in that region. And you can, on the T2-weighted image, sometimes you can kind of trace this as kind of this crescentic band, and there can be some focally low ADC also there. So again, just another pitfall to keep in mind. Also, just I think having the right windows of the windowing of the ADC map. I find the default windows that these can open up in our PACS system sometimes aren't optimal, and I really like to have these very contrasty. It's almost like when you're reading a PE study, you really want to bring up the contrast to bring out a little filling defect in the vessel here. I usually kind of crank up the contrast in these to really bring out an area of low ADC and help make that out. Sometimes there is a legitimate finding. We just have to be aware of some actual pathologic pitfalls or overlaps. And sometimes there's just no way you can tell these apart from tumor, and you will just end up having a false positive interpretation. So prostatitis is a big mimicker in the peripheral zone. This can be dark in T2, dark in ADC, show early enhancement. This was a lesion we called legitimate lesion, underwent fusion biopsy, was prostatitis, stable on an MRI a year later. Usually this won't be quite as rounded and mass-like as a tumor. It can be more geographic, have a kind of more of a linear margin sometimes. And the degree of ADC reduction will typically be a little bit more mild, at least compared with high-grade tumors. In the transition zone, the big mimicker is BPH. Stromal BPH nodules can actually show quite low ADC. Here we see this focally low ADC. This was just a BPH nodule on targeted biopsy. So I think the morphology and texture gets really helpful. Sometimes we assess this better in T2-weighted images. The transition zone tumor, compared with BPH, will generally have indistinct edges. Won't really form a nice clear capsule around it, and these can often have funny shapes, be more elliptical or teardrop shaped, rather than round or spherical like a BPH nodule. And I do think the ultra-high B-value images can be useful as well. So moving along, DCE. This has really actually been getting increasingly a more minor role as we've really gotten better with the diffusion, acquisition, and processing and interpretation. There's different ways of approaching how we interpret DCE have all been described in the literature. The most straightforward is a visual assessment, just looking at the direct images for focus of early enhancement as we scroll through these on our packs. And this is probably what's most widely done in clinical practice. Literature also reports a semi-quantitative technique, looking at signal intensity versus time curves, looking at for wash-in and wash-out, similar with breast, or doing quantitation with construction of pharmacokinetic parametric maps, such as K-trans. So I think the simple visual assessment is actually the way I find most recently is where a lot of centers are going, and this is the approach that's actually suggested in the most recent ACR PI-RADS has come out. There's been a good bit of interest in the quantification and pharmacokinetic modeling literature for a while, but it's not actually being supported by the data as improving our accuracy over a simple evaluation for early enhancement. And I certainly don't think you need fancy software to do that more advanced perfusion modeling to use DCE appropriately in your practice. And I think it's completely reasonable to do this on just a visual evaluation. When doing this, I do think it's useful to at least do subtractions, though, to sub out any increased T1 signal from hemorrhage. So here we have a dominant lesion on T2, and we can readily see the early enhancement on the subtraction image. So here we see a cine image, and we can and I can play it again. There was a little focus in the left posterior peripheral zone, and we can see it coming in quickly. And then we can just go through these time points one by one in our packs and scroll and look for that rapid focus. So in terms of how we use this in clinical practice, so here we see a patient with dominant lesion on T2, ADC. Again, the rapid early enhancement on the subtraction image, as well as a color map from a pharmacokinetic model. And again, I think either of these approaches are reasonable. I think this is useful to kind of direct our attention to areas otherwise we might have been overlooked in the other sequences and improve our sensitivity. Once we identify an abnormality in DCE, it's important to then scrutinize this area for a correlate on the T2 with a high B, the ADC. These tend to be high contrast images, so sometimes it's really good for kind of catching our attention in a certain spot. So here we had a patient who actually had 5 negative biopsies, and the first thing that catches my eye is this area in the right anterior prostate, and we look, there is a focus there on T2 and ADC, but if we were going quicker or whatnot, we might not have appreciated as readily as with the DCE. This was a high-grade tumor on subsequent biopsy. Again, this patient, 2 prior negative biopsies. First thing that catches my eye is in the left anterior prostate, but when we look, there's a crescent of low ADC and low T2 there. This was also a tumor on targeted biopsy. So the interpretation is based primarily on T2 and ADC, but we do the DCE in every case. This is a little controversial. Not all centers do it. I think I find it helpful. It can raise our confidence in an abnormality we see on the other sequences. It might assist our final suspicion scoring in some cases, which I'll mention. It can be useful if other sequences are non-diagnostic. Say the T2 has excessive motion, or there is a lot of artifact from rectal gas on diffusion. Then we have this as a kind of a backup. And again, just to identify focus that we might otherwise have overlooked. If you do see something on the DC only and there's no correlate on other sequences, and it's overwhelmingly benign or maybe occasionally a low-grade tumor, and we generally do not report such findings. So here, there is a little focus in the left posterior prostate and the DCE. We look no correlate on T2, no correlate on ADC, and we generally would not report that. Or sometimes we'll see this just diffuse increased perfusion bilaterally. That, again, is generally going to be just some inflammation. Also here, no correlate on T2 or ADC, and we would not report that finding. So the DC can be helpful sometimes for some trickier locations. Here, there's a lesion along the anterior stroma. The patient said it had 8 to 12 prior negative biopsies. That's what he wrote in the intake questionnaire. I guess it was so many he couldn't remember the exact number here. And what stands out is this rapid enhancement on the perfusion. And we look, there is some low T2 and low ADC in that region, and this was tumor on targeted biopsy. As with diffusion, there are pitfalls. Just as the neurovascular bundle can mimic a lesion on ADC, Peri-prostatic vessels can sometimes be a fake out with DCE. They sometimes can look like they're in the prostate if they're really close to the capsule. So here on the perfusion map, sometimes you can almost lose a sense of the anatomy on these and think, oh, is there a hypervascular lesion? This is just a vessel swooping around the prostate. We see the anterior and posterior extent of it, and you can even make out the flow voids on the T2 weighted image. One thing we have to appreciate is while diffusion very much has this association and selectivity for high-grade lesions, we don't quite have that relationship with DCE. Sometimes we'll see a low-grade tumor really well on DCE, and then the next patient will have a high-grade tumor, and there's DCE is normal. So this patient actually had a high-grade tumor, this confluent low T2. It's quite dark on ADC. It's bright on the high B. On the DCE, there's just some symmetric low-level enhancement, really nothing focal in that spot, and that'll happen. Some high-grade tumors, they'll be DCE negative. So moving along into reporting, how we kind of tile this together. So I think as over the past years, we really had improved and made a lot of progress in the actual acquisition and interpretation. Now I think the challenge facing the ProstateMR community is how we standardize this across centers. So this is kind of the key area to deal with today. So there have been good multi-center efforts to address this. The European Society of Uroradiology put out PI-RADS version 1 in 2012. And then more recently, the American College of Radiology had a PI-RADS version 2. It came out December 2014 or January 2015. And this is available free of charge on the ACR website. You can just Google ACR PI-RADS. It'll come right up, and you can read it. It's about a 55-page document. It sounds long, but it's actually it's quite practical and has a lot of pointers and very, I think, lays out quite nicely an approach for reporting these cases in practice. So just to kind of give some highlights, so the report is structured to provide detailed information on a per lesion basis, where we clearly identify suspicious lesions with critical information. It's a suspicion score from a 1 through 5 scale, the detailed location, size, and any extraprostatic extension. The 1 through 5 scale, they give definitions of each of these, from basically looking for significant cancer, stratifying whether significant cancer is highly unlikely to highly likely. And I think this makes the point that this is being done essentially to detect higher grade tumors, not as a test for low grade disease. Right? If your urologist wants to detect Gleason 6 tumor, this isn't really the best test to be doing. It gives fixed criteria to guide lesion assessment. There's separate 1 through 5 criteria for T2 and diffusion in both the peripheral and transition zones. So there's separate criteria for T2 in the peripheral and transition zone, and then diffusion, there's just a single set of criteria for the two zones. And these reflect various features: lesion signal, margins, morphology, and size. For diffusion, it incorporates both ADC and the ultra-high B images. And DCE, it's basically made this into a binary, just a plus minus, yes or no. Is there a visually and focus of early enhancement matching a T2 and ADC or ADC finding? And this is how they're integrated. So it's by zone. And this basically takes a dominant sequence approach. In the peripheral zone, the overall score, the overall category, essentially matches the diffusion score. So if the diffusion score is 2, the overall score is a 2, regardless of what T2 and DCE show. The one exception in the peripheral zone is that if the DCE is positive, that would bump a diffusion 3 to a 4 for the overall score. So aside from that, the overall score is the diffusion score. In the transition zone, the T2 is the dominant score because the utility of T2 for assessing the texture and morphology of these tricky nodules in that zone. So again, if T2, for instance, is a 2 in the transition zone, the overall score is a 2 regardless of other factors. The one exception being that diffusion score of 5 bumps a 3 up to a 4 in this zone. And now just to comment on what the actual diffusion criteria are, and this is the same for both zones. I'm not going to read through this in detail. It's all available on the website. But for scores of 3 through 5, all of these categories require a focal lesion. So a geographic, wispy, ill-defined lesion, that's getting a score of 2. If it's really a focal, discrete lesion, it gets at least a 3. If you read the criteria, it says that if it's markedly dark on ADC and markedly bright on the ultra-high B images, that's a 4. Right? So there's very stringent criteria here. And if it matches that, but it's also at least 1.5 centimeters, or shows gross extraprostatic extension or invasive behavior, then it's a 5. So actually, size is a factor here, and if it's either invasive or at that threshold, then we can get the highest category. So just how this works, so we have a lesion here in the left posterior peripheral zone, T2. It was equivocal, give it a score of 3. On diffusion, there's a focal area, very low ADC, very bright in the high B, not 1.5 centimeters, not invasive, so we can give that a 4. DCE is a negative, right? DCE is a plus minus. So we don't add these numbers, we don't average them. This isn't a 1 through 15 scale like the European PI-RADS version 1. We just take the dominant sequence. So here that's in the peripheral zone, it's diffusion. So diffusion was a 4, so the overall score is a 4. And that's essentially how it works. So the score is significantly associated with the presence of cancer, and in particular high-grade cancer, in numerous studies, independent of other clinical risk factors. So urologists are increasingly using these MRI suspicion scores in their decision, in their clinical decision making. So I think we need to commit clearly and unambiguously to these scores within our reports. So this was a patient who had 6 prior negative biopsies, had a progressively rising PSA. We read this as a PI-RADS 4 in the left anterior transition zone. When the urologist sees that number, that's basically telling them to go and do another biopsy, and this was tumor on fusion sampling. This patient had a prior negative biopsy, a normal MRI. We read this as a PI-RADS 1. I think it's important to put that number in there, and not just say nonspecific low T2 signal or Gleason 6 tumor not excluded. I mean, that's true. In every prostate MRI, Gleason 6 tumor isn't excluded, so that's not helpful. So actually, commit PI-RADS 1. In the literature, that has over 95% negative predictive value for significant cancer, and a biopsy was deferred. This patient had 2 prior negative biopsies. PSA is actually somewhat high, 8.6. Here there's a geographic lesion that's mildly dark. We gave this a PI-RADS 2. And in most settings, a biopsy would actually still be deferred also for a PI-RADS 2 as well as a 1. Sometimes you'll encounter this, just a diffusely heterogeneous prostate with lots of areas or candidate lesions all over the place. And how do we report these? We generally wouldn't advise giving a laundry list of all the possible foci. We'd really just report the dominant lesions. Those are the highest suspicion scores. Usually in practice, a med center will report 1 or 2 lesions, occasionally 3, not more than that. It actually states in the PI-RADS document that reporting the additional PI-RADS 2 lesions is optional. So here there was a PI-RADS 4 in the left anterior prostate, and this is what we reported. I'm going to finish up by talking with the remaining minutes just briefly about fusion biopsy, and I really think this is a big part of how this is all going to come into clinical practice. The urologists are very much embracing of this approach. They can do this quickly and easily in the context of an office visit, using the ultrasound equipment that they're already own and with the equipment that they own and they're used to using. Admittedly, there is the additional upfront investment for the fusion hardware and software, but it's still a modality that they're comfortable with. So the software performs real-time fusion between the modalities, and then can direct the needle under ultrasound guidance to the MRI lesion. It's quick, accessible to the urologist. There is, in advance, we have to load the MRI images into the system and define the targets, which I'll show. And then they can also do systematic sampling within the same session. So for the advanced planning, this is usually done by the radiologist with software supplied by the vendor for the fusion system. We segment the boundary of the prostate. Possibly this could be assisted by a technologist who's trained at your center, and then have to annotate the MR targets. This would really need to be done by the radiologist. And then the biopsy plan is loaded into the system before the start of the procedure. How PI-RADS works with this, for PI-RADS 1 or 2, significant cancer is very unlikely, so we typically defer a biopsy. PI-RADS 4 or 5 would typically perform the biopsy. PI-RADS 3, this is still a question mark, and you're going to hear different views. I don't think we have a consensus on this. So at this point, I think it still has to be tailored to the patient's individual risk profile. And I'm just going to read just some highlights from a couple of, I think, really good papers that come out on fusion biopsy. This was a meta-analysis of 14 studies on fusion biopsy to date, over 2,000 patients. And they said that our review shows that the fusion target biopsies detected more significant cancers using fewer cores compared with standard biopsy. And some studies confirm lower detection of insignificant cancer using MRI to target the lesions. And then this came out from the NIH in January in JAMA, a large prospective study of fusion biopsy in over 1,000 men. They show that target biopsy detected 30% more high-risk cancer than standard biopsy and 17% fewer low-risk cancers. The number needed biopsy with standard biopsy in addition to targeted biopsy was 200 men to diagnose one additional high-risk cancer, which would have picked up an additional 17 low-risk lesions. And this was just data from our center. I won't go through in detail, but we can see with increasing suspicion score, detection of high-risk tumors goes way up, but whereas we did not have this increasing detection of low-risk tumors. Those were more detected with standard biopsy. I'll skip past this. So my conclusions. So technical optimization of diffusion is critical. DCE is helpful, but doesn't really influence our scoring as much. This is more for localization. Be aware of the new ACR PI-RADS, as well as the role of fusion biopsy in practice. So I thank you for your attention. If you have any questions, you can email me, andrew.rosenkrantz@nyumc.org, and I'm happy to help. And with that, I'll introduce our next speaker, Dr. Kambata Koni from MGH, who'll be talking about renal stones.